Welcome to today's video lecture on madeformedical.com. Today, we're going to delve into a fascinating topic, Sjogren syndrome. In this session, we will explore the pathogenesis, clinical features, and management strategies for this autoimmune condition. Sjogren syndrome is characterized by the chronic inflammation of exocrine glands, primarily affecting the salivary and lacrimal glands. This condition leads to the hallmark symptoms of dry mouth known as xerostomia and dry eyes known as keratoconjunctivitis sicca. Sjogren syndrome is an autoimmune disorder that primarily affects the exocrine glands, leading to dryness of the eyes and mouth. It predominantly affects women with a female-to-male ratio of approximately 9:1. Sjogren syndrome often coexists with other autoimmune conditions such as rheumatoid arthritis and systemic lupus erythematosus. The pathogenesis of Sjogren syndrome is complex and involves a combination of genetic predisposition, environmental triggers, and dysregulated immune responses. Human leukocyte antigen, HLA, complex, certain HLA class Raman2 alleles, particularly HLA-DRB103, DRB111, and DQB102, have been associated with an increased risk of developing Sjogren syndrome. These alleles are believed to contribute to the presentation of autoantigens to T cells, triggering an immune response. Non-HLA genes, variants in several non-HLA genes, including TNFAP3, ER5, STAT4, and BLK, have been implicated in the pathogenesis of Sjogren syndrome. These genes are involved in regulating immune responses and play a role in the development of autoimmunity. Environmental triggers. Viral infections, particularly Epstein-Barr virus, EV, have been implicated in triggering the development of Sjogren syndrome. Molecular mimicry, where viral antigens resemble self-antigens, can lead to the activation of autoreactive lymphocytes. Hormonal factors. Female sex hormones, such as estrogen, may contribute to the increased prevalence of Sjogren syndrome in women. Fluctuations in hormone levels, such as during pregnancy or menopause, can impact the immune response and glandular function. Dysregulated immune response. B cells play a central role in the pathogenesis of Sjogren syndrome. Autoreactive B cells produce autoantibodies, including anti-SSA/Rho and anti-SSB/La, which target salivary and lacrimal glands. B cell hyperactivity and abnormal germinal center formation contribute to the lymphocytic infiltrates observed in affected tissues. CD4 T cells, particularly Th1 and Th17 subsets, are implicated in the perpetuation of the immune response in Sjogren syndrome. These T cells release pro-inflammatory cytokines, such as interferon gamma, IFN-G, and interleukin-17, IL-17, leading to further glandular damage. Dysregulation of cytokines and chemokines, including tumor necrosis factor alpha, TNFA, interferons, and interleukins, contribute to the inflammation and tissue damage observed in Sjogren syndrome. These molecules recruit and activate immune cells, perpetuating the autoimmune response. Glandular damage and autoantibodies. Autoreactive lymphocytes, primarily B and T cells, infiltrate the salivary and lacrimal glands. This infiltration leads to glandular destruction, reduced secretion, and subsequent dryness of the affected tissues. Production of autoantibodies against salivary and lacrimal antigens, such as anti-SSA/Rho and anti-SSB/La, further contributes to the pathogenesis of Sjogren syndrome. Sjogren syndrome is a chronic autoimmune disorder characterized by lymphocytic infiltration of exocrine glands, primarily affecting the salivary and lacrimal glands. In addition to glandular involvement, Sjogren syndrome can manifest with a wide range of systemic manifestations. Glandular manifestations. The most common symptom of Sjogren syndrome is a persistent feeling of dryness in the mouth, also known as xerostomia. Patients may experience difficulty in swallowing, altered taste, increased dental caries, and oral infections. They may also have a dry, cracked tongue and lips. Patients may complain of a gritty or sandy sensation in the eyes, redness, blurred vision, and intolerance to contact lenses, also known as keratoconjunctivitis. They may also experience burning, itching, and increased eye fatigue. Systemic manifestations. Approximately 50% of Sjogren syndrome patients may present with musculoskeletal involvement, including arthralgia, myalgia, and joint swelling. Non-erosive arthritis, predominantly involving small joints, is also observed. Profound fatigue is a common complaint in Sjogren syndrome and can significantly impact the patient's quality of life. The cause of fatigue in Sjogren syndrome is multifactorial, including systemic inflammation, sleep disturbances, and associated autoimmune conditions. Cutaneous manifestations. Patients may develop cutaneous manifestations, such as dry skin, rashes, and vasculitis. Purpura, livedo-reticularis, and Raynaud's phenomenon can also occur. D. Pulmonary involvement. Dryness of the respiratory tract can lead to a chronic dry cough, hoarseness, and a sensation of breathlessness. Interstitial lung disease and bronchiectasis are less common but can occur in severe cases. Sjogren syndrome can cause tubular interstitial nephritis, leading to renal dysfunction. Renal involvement may be asymptomatic or present with features of renal insufficiency, including proteinuria, hematuria, and decreased glomerular filtration rate. Extraglandular manifestations. Sjogren syndrome can also involve multiple organ systems beyond the salivary and lacrimal glands, such as GIT, the genitourinary system, and the vascular system. Diagnosing Sjogren syndrome can be challenging due to its varied clinical presentation and overlap with other autoimmune conditions. Clinical assessment. A thorough clinical evaluation is essential to identify signs and symptoms suggestive of Sjogren syndrome. Key features include persistent dryness of the eyes and mouth, xerophthalmia, and xerostomia, along with systemic manifestations such as musculoskeletal symptoms, fatigue, cutaneous manifestations, and organ-specific involvement. The presence of these symptoms raises suspicion for Sjogren syndrome. Objective measurements. Ocular assessment. Objective evaluation of dry eyes can be performed using Schirmer's test, which measures tear production, and the tear breakup time, TBUT, test, which assesses tear stability. These tests can help quantify the severity of ocular involvement. Salivary assessment. Salivary flow rates can be measured using the Saxon test or the unstimulated whole salivary flow rate test. Decreased salivary flow confirms the presence of xerostomia. Oral and ocular examinations. Clinical examination of the oral cavity and conjunctiva may reveal signs of dryness, such as erythema, atrophy of oral mucosa, decreased salivary pooling, or corneal staining. Laboratory investigations. Serology. Testing for autoantibodies associated with Sjogren syndrome is crucial. Anti-SSA/Rho and anti-SSB/La antibodies are the most specific and commonly detected autoantibodies. Other antibodies, such as rheumatoid factor, RF, and antinuclear antibodies, ANA, may also be present. Erythrocyte sedimentation rate, ESER, and C-reactive protein, CRP. These markers of systemic inflammation may be elevated in Sjogren syndrome, although they are nonspecific. Rheumatologic assessment. A comprehensive rheumatologic evaluation should be conducted to assess for the presence of other autoimmune conditions and to evaluate the extent of systemic involvement. Salivary gland biopsy. Minor salivary gland biopsy from the lower lip is a valuable diagnostic tool. Histopathological examination reveals lymphocytic infiltrates, focus score determination, and evidence of glandular destruction. Additional diagnostic tests. Ocular surface staining. Fluorescein or lissamine green staining can identify corneal or conjunctival epithelial damage, supporting the diagnosis of ocular involvement. Imaging techniques such as salivary gland ultrasonography or scintigraphy can assess glandular function, detect structural abnormalities, and aid in the diagnosis. Tests such as salivary scintigraphy, salivary flow scintigraphy, or salivary gland magnetic resonance imaging (MRI) can provide functional and structural information about the salivary glands. Sjogren syndrome primarily affects the exocrine glands, resulting in dryness of the eyes and mouth along with systemic manifestations. Let's explore the treatment options available. Treatment goals. Symptom relief. Alleviating dryness of the eyes and mouth, improving oral hygiene, and minimizing discomfort. Preventing complications. Managing complications such as dental caries, periodontal disease, and ocular complications. Controlling systemic manifestations. Addressing systemic symptoms such as fatigue, arthralgia, and other associated autoimmune conditions. Improving the quality of life. Enhancing the patient's overall well-being and functional status. Symptomatic management. Artificial tears. Lubricating eye drops, ointments, and gels can provide relief for dry eyes and alleviate symptoms of keratoconjunctivitis sicca. Saliva substitutes, moisturizing mouth sprays, oral gels, and lozenges can help combat xerostomia and enhance oral comfort. Pilocarpine and Sevenline. These medications can stimulate salivary gland function and increase saliva production in patients with xerostomia. Eyelid hygiene. Proper eyelid hygiene, including warm compresses and lid scrubs, can improve ocular symptoms and reduce the risk of infection. Dental care. Regular dental visits. Encourage patients to maintain regular dental checkups to monitor oral health and address any dental complications promptly. Good oral hygiene practices. Emphasize the importance of brushing with fluoride toothpaste, flossing, and using antibacterial mouth rinses. Systemic management. Non-steroidal anti-inflammatory drugs, NSAIDs. NSAIDs can be used to manage joint and muscle pain associated with Sjogren syndrome. Hydroxychloroquine. This medication may help control systemic symptoms and reduce inflammation in some patients. Immunosuppressive therapy. In severe cases with significant systemic involvement, corticosteroids, immunosuppressants, e.g., methotrexate, or biologic agents may be considered to control inflammation and modulate the immune response. Sjogren syndrome is a chronic autoimmune disorder characterized by exocrine gland dysfunction, primarily affecting the salivary and lacrimal glands. Prompt recognition and management of this condition are crucial to alleviate symptoms and prevent complications. By understanding the pathogenesis, recognizing the clinical features, and implementing appropriate management strategies, we can provide comprehensive care and improve the quality of life for patients living with Sjogren syndrome. And that brings us to the end of today's video. I hope you found the information helpful and informative. If you enjoyed this video, don't forget to give it a thumbs up, and don't forget to sign up for a premium membership on our website, madeformedical.com, for more content like this.